Welcome to the history of health information technology in the U.S. There have been many challenges both in healthcare and health information technology over the past 50 years. In this lecture, we're going to explore the background and increased interest in health information technology that we're seeing today, along with the inferences between electronic health records and other computing applications that are used in the care of patients. Not just the computer technology pieces, the hardwares, the softwares, and all the softwares including billing and scheduling. There have been many changes in both healthcare and health information technology, and we're going to talk about defining informatics, reviewing this history of healthcare informatics, and relating that to health information technology, along with how health information technology has evolved over the past 30 years and some of the goals and visions of high tech. So what is informatics? It is the collection, classification, storage, retrieval, and dissemination of recorded knowledge. The use of technology or computer systems have been used in the last 20, 30 years related specifically to healthcare, and now informatics is taking on a specific definition that is the use of technology or computer systems to collect, store, process, display, retrieve, and communicate timely data and information in and across healthcare. There's medical informatics, there's clinical informatics, and there are nursing informatics. Medical informatics started out as a process of being able to collect data on patients to try to see things like disease process trends, trying to improve patients' survivability or decrease morbidity in patients. Nursing informatics and clinical informatics has taken that to another level where we're looking at not just the data that we are collecting and analyzing from a statistical perspective, but also the way workflow, the way that data is collected. So workflow, the type of devices that we're using, the type of languages used on those devices, and trying to get some standardization and some help in order to make the data that we're inputting make sense when we retrieve it for the statistical analysis. If you always hear things in the computer world, we say things like garbage in, garbage out, or in data, in statistical analysis, it's data garbage in, garbage out. And so informatics as a whole is taking into that account, how is the data getting in there in the first place? So how did this all start? Well, informatics, if we think about it as being that classification, storage, and retrieval of information, this has been going on for thousands of years. We can look at Hippocrates, right? The Hippocratic Oath. Hippocrates has over 70 works that talk about the regimen for health, sacred diseases, and complicated pharmaceutical type mixtures, herbal remedies. All of that was classified, was stored in a format that people could retrieve it so it could be shared. Similarly, back over 5,000 years ago, we have ancient written texts that had medical formularies or medicines that were written down. Again, the process of storage, classification, and retrieval of this data so it could be disseminated and we could learn from it. A database for those of you that are doing computers. Some more recent health informatics persons who didn't even realize that's what they would be called today. We have John Snow. He didn't know what was causing cholera. He didn't know about germs and those kinds of things during this period of time, but he was able to use data in a database type format and statistical inferences to find that there was a specific pump that could be associated with causing the sickness. William Farr also worked on this and quickly discovered that diseases are more easily prevented than cured, and that the first step to their prevention is the discovery of their causes. So using this statistical methodology, he was able to define 27 fatal disease categories and try to get common language between medical providers, so they all were talking about the same thing. Back during his time, people were calling dysentery bloody flux, or diarrhea might have been looseness or purging or bowel complaints. And he was trying to find one term or synonym terms so that everybody could speak a common language and understand what they were talking about when you went from person to person or doctor to doctor during that time. The use of this standardized nomenclature allows for simplified classification and categorization of data, normalizing your database. William Farr collected and stored this and challenged his medical colleagues to evaluate the medical contributions of the country based on this liberal scientific basis. You've all heard of Florence Nightingale at some part during your lifetime, not just because she did nursing, but her biggest contribution had to do with the statistics that she was able to do. And not so much that she collected, categorized, stored data, and was able to put it into tables and make inferences and find that the data she was able to present, which was that the soldiers were dying from illness more than they were dying from their actual wounds they received. It wasn't the gunshot wound, or it wasn't the sword wound that killed them. It was because they got one of these diseases or infections while they were trying to heal. And sometimes even just being out in the environment was subjecting them to things like cholera and dysentery without even having any wound. So again, what she's noted for, though, is the way she was able to present the data. So she took her database that she had created and she was able to put it into a pictorial format. And this visual interpretation she was able to present to Queen Victoria helped someone who couldn't crunch all the numbers see visually what was going on, and it has a very powerful impact. So throughout the 70s, we had some more scientific breakthroughs, and historically, computers were beginning to be used in research. Mainly they had been used in order to do like billing or those kinds of data collection processes, but it was realized that knowing who these people were that were coming in to be seen at physicians' offices, we could take those and start putting them and categorizing those people into figuring out their disease processes. While there was some clinical computing being developed by medical informatics and academia centers, they rarely found their way into operational uses. And you can see here, I mean, this is how big computers used to be. This would probably fit inside your iPhone right now, the amount of technology that's in this picture. So throughout the 70s, we had an increased number of medical students. People, whether it was for GI bills, being able to go back to school, it was a prosperous time. People were starting to look at it. Wasn't just the wealthy anymore that could go and become physicians, and there was increases in colleges and places available. So there was increase in medical students, increase in research funding. We started a fee-for-service practice model in insurance. And there were few controls on physicians at this time, and it was realized that we might need to start looking at that. Is everybody practicing medicine similarly? Clear back to the way William Farr was trying to describe it back in the 1800s. Healthcare costs started to go out, and computers started to get smaller. In an effort to collect data to monitor patient diagnosis, physician care practices, and regulatory requirements, programmers began developing computer documentation and inputs. Throughout the 80s, people started to become empowered. They were becoming educated themselves and asking the questions of their providers and beginning to do their own research on why do I feel this way and how can I get better. The civil rights legislation in the 60s continued to exert influence, and we have women's liberation, and it was also the beginning of personal computers. We still had specialists, but more importantly, we had children beginning to use computers. Back in the 80s, back where I'm from, Apple computers were first introduced into the schools. Part of it as a marketing ploy. If they got them in the schools in the hands of children, they would be more likely to be purchased than for home use. And these were those first desktop computers. Again, throughout the 80s, we got into prospective payment, or DRGs, if you've heard of them, that are controlled by Medicare, Medicaid services. And we had increased HMOs, which were another form of trying to regulate the amount of payment for a particular service that you might be being provided. It was saying things like you couldn't go see a specialist unless your primary care provider said you could go see them. And it was an effort to eliminate costs so that somebody that had a sore throat didn't go and see an ENT specialist, which would cost more or charge more if their primary care provider could see their sore throat and simply prescribe them an antibiotic for strep throat. Again, physicians were increasing, the number of physicians graduating, they were starting to specialize, and there was more competition for NIH, or the National Institutes of Health, funding. And then we move into a more modern era where we have the World Wide Web, and it's becoming a consumer emphasis. We've got WebMD now. And in fact, the internet had existed earlier as a mechanism for communication about scientists and military. Until the late 90s, it combined the idea of hypertext and clickable clicks that we're familiar with today. So it wasn't quite as end-user friendly. And now with that end-user friendliness, people have been able to go out and find their own information. A report generated by the Institutes of Medicine made significant media attention because it suggested up to 98,000 people die every year due to medical errors. More importantly, the report laid out a compelling argument that most errors in medicine are the results of poorly designed systems. So we've begun to use some systems, whether that is electronic systems or whether it's processes in hospitals, that were potentially creating these errors. So maybe we had a checklist of washing your hands and doing these steps before you did a procedure on a patient, but the equipment you needed to do those steps maybe weren't readily available. So your hand washing sink might have been 50 feet down the hallway from where your hand antiseptic was, from where the cart that had the procedure items was in another location in a closet. So by the time you washed your hands and used your antiseptic, they were all dirty again by the time you got your cart. So we had the step-by-step procedures on what to do, but those systems of where to place those steps or the processes we needed weren't easily and readily available. In addition, we had problems with the electronic systems, nomenclature. Clear back, William Farr talked about it, but the nomenclature of things weren't in sync. And so the culture of medicine didn't support open communication. There was fear of nursing talking to doctors. You didn't question what a doctor did. So even though this report had shocking statistics, it didn't present any new data. They were things that we already knew, but it compiled the results, and when released, critics argued that these statistics were inflated, but the general consensus among the experts were that the statistics were accurate and even probably an underestimation. Two years after that report, there was a second report that was called Crossing the Quality Chasm, and it made several important contributions to the national quality movement. It defined quality care into 6 components: patient safety, effectiveness or evidence-based, efficiency, so that it wasn't wasteful resources, timeliness, patient-centered, and equitable. Effectiveness, obviously patient safety speaks for itself, but effectiveness had to do with care that's evidence-based, and when we talk about evidence-based, it means there's research that supports it. Yes, we all know we're supposed to wash our hands, and we're supposed to wash our hands while we say the alphabet. That gives us 30 seconds of hand washing. But that took a research study to prove that vigorous scrubbing of our hands, not just running them under water, killed the germs. It's not so much about the soap, it's actually the length of time and the aggressiveness of the rubbing, the friction between the hands that kills most germs. That's evidence-based. Quality and timeliness and efficiency are sort of hand in hand, and traditionally healthcare had been provided in such a way that the comforts of medical personnel were more important than the comforts for the patient. And now they're suggesting that high quality care must take in consideration the needs of those patients, which leads us into a patient-centered atmosphere where we're looking at their needs from a whole person perspective, from religious and spiritual to emotional to cultural and physical, in addition to other needs. An example of that was we have a large Hmong population in Missoula, Montana, and one of the big cultural and spiritual parts of that culture of that group of people is these prayer bands that they have on their wrists. And it wasn't understood because of language barriers and other reasons. When they would come into a hospital, we cut that stuff off of them, particularly if you're hurt very badly or we need to start an IV. We won't let you keep those things on your wrist. And it caused a lot of disturbance, a lot of distrust of the Hmong people until we realized that how sacred those bands are that they put on their wrists when they're praying for their individuals. And so it's a practice. You do not cut those off of that culture when they come in the hospital. We will find a way to work around it so that we can meet their needs, and that's just an example of treating the whole person. And quality care is equitable access. And when we talk about access, I'm not talking about just the ability to pay. It's also the ability to get where you need to be physically. Out on some of the reservations, in some rural areas, it might be 50, 100 miles just to get to some place that can provide you medicine. And we're not talking necessarily the hospital. We're just talking about a mid-level provider or a physician's office. They may not have x-rays. They may not have some of the testing available, but just to be able to see somebody that has more knowledge than you do about healthcare could take a full tank of gas, the ability to have a car that is running. And some of these people in rural areas don't have some of those basic things that you and I might take for granted. And clearly there's other racial, gender, geographic, and many disparities that need to be achieved and addressed before we can reach the 21st century health system that's outlined in this report. But we can help improve with health information technology. As we see more use of computers in research, we've got faster responses to that research. And McLean developed a system for the National Library of Medicine so that we can do that. And some of the places I'll have you go is out to the library to pull some of these research articles and things that are being done. Aging baby boomers are affecting health costs. Technology is improving both as patients and their caregivers are more comfortable with it. There's been an increase in telehealth, which is the ability to have remote access to health care. I have experience with burn patients who, instead of having to drive to Salt Lake or drive to Seattle, can now be treated over the internet for their exams, their follow-up exams, and looking at the bandages and helping somebody walk through rebandaging without actually physically having to be there with the patient. Another characteristic since the late 90s in the healthcare environment is more interest and more use of clinical computing, and that's where you're hearing about all the electronic medical records and the electronic healthcare records that are being developed. It's also led to an increase in HIPAA, or the Health Insurance Portability and Accountability Act. And it was passed in 1996 and continues to be reviewed and re-reviewed as technology improves with portable devices, flash drives, access over the internet to personal health records that people maintain themselves. So reasons why health information technology has expanded. 2004, we had presidents were pushing for electronic health records for everyone by 2014, and we're now in 2013. We developed the Office of the National Coordinator for Health IT and certifications for health information technology. In 2009, we had the Health Information Technology and Economic and Clinical Health Act, or the HITECH Act, which provided substantial dollars to develop courses and education specifically related to health information technologies. Any bit of information that's available on a computer must first be digitized. And so this has been another huge process of getting into an electronic records mode. And what happens if the electronic process isn't available during like a downtime or a power outage? When we transition from to electronic, we have to think about how do you currently do it on paper. So we do a workflow analysis, and that's part of what healthcare technology, information technology is doing. What's your outcome? How does it currently exist? How can we make it exist in the electronic environment? And remembering, it's not going to be an apples to apples type comparison. We need to spend time out with those end users and see what they're currently doing and see if we can improve the process from everything from how many steps it takes to get them from one place to another to their ergonomics. Are they having to reach to get to the electronic devices? Then we implement those changes and then we reassess. And here's our challenge. Anytime there is a change, we meet resistance. And then they're not sure. Is it really going to work? Is it going to be safe? Is the power always going to stay on? Am I always going to be able to access this? Then we begin to assimilate and they start to use it and they understand it and they can see its benefits and they start to tell others about it, and then we get to a fully integrated perspective. The HITECH Act of 2009, which was part of the American Recovery and Reinvestment Act, represents the first time in history that there is a reasonable funding to move us forward into this healthcare information technology world. And in many ways, it can be seen as being made possible by the events over these past 50 years. Again, we've got some barriers that are preventing health information technology from being adopted. Cost, impact on productivity, manpower. And adoption is not just enough. Once they begin to use it, they must use it appropriately. We're talking about standardization. We're talking about nomenclatures. We're talking about your database. If you don't put things in the correct fields, then the database gets corrupted and it's not easy to abstract information from there. And it must be able to be shared. So it's got to be codified, standardized. The nomenclature has to be in such a format that if I'm going to talk between community and St. Patrick's Hospital and I've got a Cerner system and an Epic system, I've got to be able to have those two systems talk to each other in some form. The data has to be able to talk. And we've got to be able to lock it down, keep it private and secure, and not be able to be as easily hacked. Think of just like your banking information. We need better incentives. Currently, there is a payout. If you've heard of all the talk of EMRs, part of it is we have to get some certain things done by 2013 and by 2015 in order to receive certain dollars from the government to help offset the cost of all the hardware we've had to buy, the software licensing agreements, and the time and money spent on training resources. So this is just a brief overview. I apologize, the lecture is very quick, but I hope you got some things out of it and look forward to talking to you again soon.